Good afternoon, everyone. My name is Shiza Wajih Siddiqui, and today I'll be delving into a crucial aspect of cardiovascular health that goes hand in hand with heart failure, anemia. In this presentation, we will explore the intricate relationship between anemia and heart failure, examining its prevalence, underlying mechanisms, clinical implications, and current strategies for diagnosis and its management. So let's dive into this discussion on anemia in the context of heart failure. Starting with some definitions. So as basic as it can get, heart failure means that the heart isn't pumping as well as it should. And because of that, the body isn't getting enough of the oxygen-rich blood that it requires to function appropriately. Whereas anemia, as per the WHO, has been classified as hemoglobin levels less than 12 gram per deciliter in case of women and less than 13 gram per deciliter in men. However, these may vary with different ages, pregnancy status, different altitudes, as well as to smoking status. Talking about the disease prevalence, so the global burden of heart failure itself stands at 64.34 million as of 2017. And in those patients, the prevalence of anemia has been seen in 9% to 69.6%. And the risk of hospital admissions and mortality is nearly 46.8% in patients of anemia as compared to the 29.5% in non-anemic patients, making it an important part of a heart failure discussion. And the presence of other comorbid medical conditions like chronic kidney disease and advanced age have also been linked with the increased prevalence of anemia in heart failure patients. Now, what is the pathophysiology of anemia in heart failure patients? So the pathophysiology is multifactorial, including the presence of iron deficiency, the presence of chronic inflammation, the presence of impaired erythropoietin levels, the involvement of the renin-angiotensin-aldosterone system, as well as a few other causes. Starting with iron deficiency anemia. Now, we all know that iron is an important part of erythropoiesis. It's important in oxygen transport as well as the function of some enzymes. So iron deficiency in heart failure has been a common occurrence, and it has been linked with increased severity, poorer prognosis, and outcomes. So a study which was done with 148 patients showed that 148 patients of heart failure showed that 43% were found to have a specific cause, and including that, amongst those 43%, 5% had iron deficiency anemia as their cause. And another study, which was done in 2013, showed that amongst 1,506 patients, 753 had iron deficiency and 426 with anemia. Now, the diagnosis of iron deficiency in heart failure is based on either a ferritin level of less than 100 microgram per liter or a ferritin level of less than 300 microgram per liter with a transferrin saturation level of less than 20%. And this is as per the European Society of Cardiology. Now, there are two kinds of iron deficiency that can be noticed in patients with heart failure. It's either absolute iron deficiency, seen in 15% of patients, which is due to basically the decrease in levels of iron in the body. And it has been linked with factors like anorexia, cardiac cachexia, and decreased iron absorption, which is seen in heart failure patients. And the other one being functional iron deficiency, which was seen in 18% of the patients, where there are sufficient iron levels in the body, but they are not adequately distributed to target tissues, and this might be due to the maldistribution. Now, chronic iron deficiency in heart failure, it has shown to cause myocardial dysfunction, impaired oxygen metabolism, as well as reduced levels of reactive oxygen species protective enzymes such as glutathione peroxidase, superoxide dismutase, as well as catalase. Now, iron deficiency is associated with reduced exercise endurance, poor quality of life, and increased morbidity and mortality even without the presence of anemia in heart failure patients. Next, we have chronic inflammation. Now, the chronic inflammation leads to anemia, leads to a normochromic normocytic anemia. And the pathophysiology behind this is the increased production of pro-inflammatory cytokines such as tumor necrosis factor alpha, interleukin-6, and interleukin-6, which have been seen to be produced by the cardiomyocytes and the fibroblasts, as well as interleukin-1, which is released by the endothelial cells, along with increase in levels of the acute phase protein hepcidin. Now, the tumor necrosis factor and interleukin-6 cause inflammation and have been linked with inhibition of renal production of erythropoietin, as well as inhibition of the proliferation of the bone marrow erythroid progenitor cells. Whereas interleukin-6 causes an increase in level of hepcidin, and hepcidin produced by the liver causes decreased duodenal absorption of the iron, as well as decreased ferroportin levels and a decreased release of iron from the reticuloendothelial system, causing both functional and absolute iron deficiency. And these pro-inflammatory cytokines have been shown that their production has also been linked in cases of heart failure due to bowel edema or due to tissue hypoperfusion. And these have been linked with poorer prognosis and outcomes in these patients. Next, we have erythropoietin levels. Now, erythropoietin is an amino acid glycoprotein hormone, which is primarily synthesized by the renal cortex in adults and in the liver in the fetuses. Now, erythropoietin is regulated by hypoxia-inducible transcription factors, which are triggered by renal hypoxia and low hemoglobin levels. And these elevated levels of erythropoietin in heart failure patients, which have been shown to be unrelated to hemoglobin levels, are associated with increased morbidity and mortality. And the cause behind why erythropoietin is elevated in heart failure can be due to chronic inflammation, as discussed in the previous slide, leading to an increased erythropoietin production. And by increased erythropoietin production, as these pro-inflammatory cytokines basically impair the expression of erythropoietin, which leads to erythropoietin resistance in the bone marrow, causing an increased production of erythropoietin. And it can be due to angiotensin-induced erythropoietin production, as well as synthesis by the myocardium due to oxidative or metabolic stresses. Next, we have the involvement of the renin-angiotensin-aldosterone system. Now, the renin-angiotensin-aldosterone system is activated in cases of renal hypoxia, and this leads to activation of renin in the kidney, leading to the conversion of angiotensin, leading to the activation of angiotensinogen, leading to the conversion of angiotensin 1 to angiotensin 2, in turn stimulating the aldosterone to increase absorption of sodium and water. Now, the RAS also influences the production of erythropoietin, and it's mainly done through two ways. One is that angiotensin 2 causes a decrease in the renal blood flow, increasing the oxygen demand, resulting in a reduced PO2 and increase in the erythropoietin synthesis. And angiotensin 2 also directly stimulates the production of erythroid progenitor cells in the bone marrow itself. Now, angiotensin ACE inhibitors and angiotensin receptor blockers are used in the management of heart failure, and they have been shown to slightly decrease hemoglobin levels by lowering the erythropoietin production and the erythroid progenitors, as well as they prevent the breakdown of an acetylserine aspartyl lysyl proline, which is an inhibitor of hematopoiesis, thus decreasing hematopoiesis itself. Now, a few other causes that have been linked with the presence of anemia in heart failure patients. It can be due to activation of the renin-angiotensin-aldosterone system causing hemodilution and pseudoanemia. And it can be due to medications like beta blockers, especially carvedilol, and and digoxin who have been linked to decrease hemoglobin levels in heart failure patients. Now, what are the diagnostic guidelines of anemia in heart failure patients? Now, no such specific guidelines for anemia as a broad topic have been found, but the guidelines from the European Society of Cardiology does consider iron status, ferritin, and transferrin saturation levels, and it has been recommended to assess these for newly diagnosed patients as well as for patients previously diagnosed with heart failure, and they should be routinely checked in follow-ups and post-discharge care, with the diagnostic criteria being the same as mentioned before for iron deficiency. That's serum ferritin levels less than 100 microgram per liter, or a serum ferritin level of less than between 100 and 200 microgram per liter with a transferrin saturation of less than 20%. Mean corpuscular volume, mean corpuscular hemoglobin concentration, and serum iron alone are not reliable markers for assessing iron deficiency in heart failure patients. Now, discussing the clinical impact of anemia in heart failure patients, there have been multiple studies done over time in the past 2 decades, taking into consideration different criteria for classifying heart failure, whether it being the NYHA class or the left ventricular ejection fraction, and multiple criteria for, again, diagnosing anemia in heart failure patients. Some took hemoglobin levels, which was as per the WHO criteria. Some studies took into account hematocrit levels, and they found they all had similar outcomes, showing that anemia in heart failure patients has been linked with increased severity, poorer outcomes, increased levels of hospitalization, increased levels of morbidity and mortality. Moving on, the management of anemia in heart failure patients. So there are a few options that have been looked into, starting with RBC transfusion. So the role of transfusion in the correction of hemoglobin levels in heart failure patients has been shown to only offer a temporary benefit, as well as increased risk of adverse effects, making its usage limited and unsuitable for long-term management, as well as based on case by case. Now, iron supplementation is another proposed management modality, with oral iron supplementation showing limited efficacy as due to reduced gastrointestinal absorption and compliance issues. Two studies that were conducted, the Iron Out heart failure trial, showed no improvement in exercise capacity with high-dose oral iron therapy. And another trial, the Iron Heart Failure Study, which compared the use of IV iron with the use of oral iron, showed that IV iron in the form of IV iron is preferred due to its superiority. Another randomized placebo-controlled study showed that IV iron therapy without the addition of the recombinant human erythropoietin showed improvement in left ventricular ejection fraction, the NYHA class, exercise capacity, and the quality of life in heart failure patients. Another trial showed similar outcomes of that IV iron has improved hospitalizations, has improved symptoms and functional capacity, but showed no improvement in mortality rates in heart failure patients with iron deficiency. Multiple other placebo-controlled trials showed that the use of IV iron in the form of ferric carboxy maltose significantly reduced risk of hospitalization, but had no effect on mortality and survival. The most recent trial, which was the Iron Man trial, which was conducted in 2022 in the United Kingdom, which was a prospective randomized trial, showed that similar outcomes as previously conducted trial, that there was a reduction in total heart failure hospitalization, but it also showed a reduction in cardiovascular related deaths with the use of IV ferric derisome maltose. And the dose of this ferric derisome maltose was based on the patient's body weight and hemoglobin levels. And because after the outcome of this trial, the European Society of Cardiology now recommends the use of intravenous iron in the form of ferric carboxymaltose or ferric derismaltose for the treatment of iron deficiency anemia in patients of heart failure. And this has also been recommended by the American College of Cardiology. Now, although we discussed in the pathophysiology that that erythropoietin levels are increased in heart failure patients, erythropoiesis-stimulating agents as a treatment modality for anemia and heart failure has also been studied. And agents like apopoietin alpha, apopoietin beta, and darbepoietin alpha have been studied. And these agents have undergone multiple meta-analysis and multiple trials over the year, taking into consideration the New York Heart Association classification and the quality of life among heart failure patients. The outcome was that they do not substantially affect mortality or hospitalization rates, and they pose an additional risk of thromboembolic events. Now, the two trials which were conducted were one was the RED heart failure trial, which which involved darbepoietin alpha in treatment, showed no reduction in mortality and or hospitalization rates, and an increased level of thromboembolic event. And the Stamina HEFT trial, which also had similar outcomes, but it did not, but it did note a lower risk of morbidity and mortality compared to the previous trials. And as per the American College of Cardiology 2022 guidelines, it's recommended to not use erythropoiesis-stimulating agents for the treatment of anemia in heart failure patients. So now the final takeaways from this presentation are that anemia is a fairly common finding in heart failure patients, affecting significant percentage and contributing to increased morbidity, mortality, and hospital admissions. And the pathophysiology of anemia is multifactorial, and it has been linked with iron deficiency, chronic inflammation, and abnormal levels of erythropoietin, as well as the involvement of the renin-angiotensin aldosterone system. Now, diagnostic criteria for anemia and heart failure patients has has only the diagnostic criteria for iron deficiency, considering serum ferritin levels, transferrin saturation, and hemoglobin levels. And the management options, the treatment modalities for anemia and heart failure patients include the use of intravenous iron supplementation, as it has shown to improve quality of life and functional capacity, whereas erythropoietin-stimulating agents have showed limited benefits and associated risks. So to conclude my talk today, anemia is a significant concern in heart failure patients, impacting the prognosis and outcomes. Now, early detection and proper diagnosis and targeted management, especially with intravenous iron supplementation, can play a crucial role in improving the quality of life and clinical outcomes in these patients. However, further research is needed to establish optimal treatment strategies and diagnostic guidelines. Thank you very much. These are my references. Thank you.